So before we jump into the M of medications, we are going to have a culture change challenge. Oh no, Carmen, I'm nervous.
No,
I know I'm
don't
not
be.
the only one. I'm not the only one who's
Don't
nervous.
be nervous. Okay, notice everyone, I've changed it from a culture change moment to a challenge because, hey, that's what it is, right? For all of us. So I'll take the next slide, please. And today I'd like to just present the word ageism. We haven't really brought that up too much, I don't think yet. Probably we all know what it is, but prejudice or discrimination on the basis of a person's age. In fact, ageism can go both ways, right? We can have preconceptions about teenagers, for instance, right? And so today, the challenge right now is there ageist language even in the field of aging? Isn't that ironic? And I know that some of you know some of the words and phrases have come up. And so I would like to invite everyone to try to think of at least one idea, one word or phrase. Okay, it doesn't have to be just a word in the chat box, and then I'll come back to it and I'll share some ideas with you. Thank you.
Carmen, do you want to comment on any of the comments in the chat box? You're muted.
I was going to do it later.
Oh, okay.
Yeah.
That's fine. All right. Well, you can collect them then. Pretty good. All right. I was having that little momentary pause there.
That's okay. Thank you.
Wondering if we were going to respond to that, but let's move on. This is part of the 4-part series and the framework around what's called age-friendly healthcare. And this is the 4 M's. Okay, so just as we'll talk about them, the 4 M's of what matters most: medication, mobility, and mentation or mind, depending upon your preference for which term you want to use. So, and for those that are, I see we have some new folks here, so that's wonderful. Thanks for jumping on to this series. Just by way of introduction, my name's Donald Jurovich, and I'm a professor of geriatrics and the chairman of the geriatrics department, which is, I think, the 10th or 11th geriatric department in the country, which is pretty cool. And we're so grateful for the support that we have for a designated department as opposed to a division, which most medical schools have. So with that said, we can move to the next slide. All righty, we're going to put up the poll here. So the first question is, the best clinical tool to recognize unsafe medications in older adults is one of these: Beer's List, the physician's desk reference, the Micromedics, or the Cage. So please put your answer. And then the second question is, deprescribing medications in the older adults does what? Gives time back to the nursing home staff, reduces drug-drug interactions, reduces falls, all of the above. So if you can put your best answer, that would be wonderful, and submit that. Okay, and then maybe Jennifer, we can at a later time look at the results if we can at the end of the presentation here. So today we want to talk about the effect of age on pharmacokinetics, how their medications are processed in the body. We want to look at the issues of polypharmacy, basically 6 or more medications, and we want to find ways to deprescribe fundamentally. Next slide, please. So here's the reminder of the 4 M's. Now, just as also a reminder that when you are an age-friendly healthcare institution facility, and we're inviting all nursing homes and assisted living to join this movement. So this is why we're introducing this concept. You can sign up for age-friendly healthcare through the Institute for Healthcare Improvement. It's a rolling admission, so you can just sign up anytime you want. And basically what it is to document the assessments for these 4 different components of the 4 M's. And as you can see, the medications really influence things like what matters. So like a medication that causes fatigue, that's going to influence what matters when somebody says that they just don't want to be feeling tired all the time. Likewise, medications can influence mobility. So there are a set of medications that can cause falls or contribute to falls. So that obviously impacts mobility. And then also mentation. So high anticholinergic medications such as Tylenol PM, Benadryl, and the such that are often viewed as over-the-counter drugs can have a profound effect on mentation and predispose older adults to delirium. So that's why we want to talk about medications as one of the essential 4 M's. Next slide, please. So the balance here, and this is a little complicated slide, but basically what we're trying to get at is that you want to do more good than harm, right? So as the medication profile goes greater into the red zone, we just have less confidence that it's going to cause more problems than it's worth. So that's the bottom line here, and we have to kind of be mindful of that, those trade-offs, and where our comfort level is from the ratio of benefit to risk. Okay, next slide, please. So part of the issues with medications and their, quite frankly, overuse in the older adults is that we don't have enough people trained to know about older adult healthcare, and so this is why this kind of program exists. The other problem is that second point is that drug safety really becomes of greater concern in people that we consider vulnerable, those frail older adults, and pretty much with the activities of daily living deficit in long-term care, that's the vulnerable population that we're talking about. The drug prescriptions are, the guidance is really pretty happen chance. We don't always know what the best practices are for proper dosing. A lot of times there will be guidance about lowering the dose in the older adult population, but as a geriatrician, our rule of thumb is always go low and go slow when you start escalating the medications. And then the other point that we'll just kind of go over is that a lot of the research, clinical research that looks at medications do not include older adults, and certainly not the frail older adult population. And if you think about it, why would a pharmaceutical company want to include frail older adults where one of their medications might honestly kill them? And it's a pretty crass way to say it, but that is the truth. And then finally, we know that a third of older adults have 5 or more chronic conditions. And so that's another reason why they exclude them from the studies, is because they want to have a pure focus on blood pressure or asthma. They don't want these people with heart failure and diabetes and, good gracious, everything else that comes with the kitchen sink. Next slide, please. Yeah, and just emphasize that, like in an oncology, cancer trial, you can see the percent of patients that are 75 and older. It's just, smidgen under, 10%. So they're just not being studied. Next slide, please. So part of the issue is that there's a lot of heterogeneity in the older adult population. So the older we get, the less we look alike physiologically. And so you've got this great variation as to how a medication may impact even the healthy people on the left side, and even more so on the frail side. And so all these factors are going to play, in terms of cognition, physical status, as well as their psychosocial status. And part of that psychosocial status may be ability to afford medications. So next slide, please. And we've got this gray wolf here that's staring us down. This is the dreaded and sometimes sneaky adverse drug events. They typically are under-recognized, and a lot of times providers will just say, that diarrhea that you're complaining about, or loose bowels, probably something that you ate, or, you know, they wouldn't say, oh, it's one of your medications. And so then guess what? They prescribe something like Lomotil, Pepto-Bismol, or whatever, and they start adding more medications to a regimen that's already causing side effects. And so a rule of thumb is that if you have new symptoms, you got to consider whether it's medication induced. And the other rabbit hole that providers fall into, quite honestly, is that they say, well, there's no new medications. Well, you know, an old medication can start a side effect months later, okay? And that includes allergies. And so you really have to think about the profile of what the medication might be associated with. Next slide, please. So the risk for adverse drug events are the oldest, those over 85. As I mentioned earlier, polypharmacy with 6 or more medications. Polypharmacy used to be 5 or more medications, but then all of a sudden they had to notch it up one more because everybody's taking medications. So if you have a low kidney function, so somebody particularly with a EGFR, an estimated glomerular filtration rate of less than 30, are really at high risks for medication interactions. This is a big one, multiple prescribers. I mean, I get, you know, prescription renewals like yesterday in my clinic. There were 5 different prescribers, you know, they wanted me to, you know, refill all these medications. And that's why we try to get, you know, primary care. And like, if you're at my clinic, you know, primary care doctors are, you know, fly-by-nighters. They're, you know, the high turnover. You know, I'm constantly getting patients saying, are you going to be around for a while? So I said, well, I've been here for 7 years, so hopefully the answer is yes. But you can see what I mean, you know, with these multiple prescribers. Next slide, please. And just gives the, if you focus on the center panel here, the probability of a drug-drug interaction increases exponentially, right? So if you've got 5 to 9 medications, and that means everything, right? That could mean baby aspirin along with your multiple vitamin pill. You got a 50-50, you might as well flip a coin as to whether you're going to get a drug-drug interaction. So the chances are pretty high once you get that. And I think that's just massively underappreciated. And you can see on the left panel there, that the number of medications that are associated with all these morbid conditions, you know, including frailty. So, you know, it would be true to say that the more medications you're on, the more likely you are to be frail. I just reviewed a study as part of our geriatric fellowship. You know, we have a journal club that we collaborate with several universities, and the article that we were reviewing for Journal Club revealed a surprising result to me. You know, when you talk about frailty, it indicated that people who had a hip fracture, got their hip fixed, and then left the hospital, that 60% of them never walked the same that they did before their hip fracture. I mean, that's 2/3 of the people that have a hip fracture never walk the same ever again. So, you know, you add to that the medications that induce the fall. I mean, you can see that we're having some irrevocable health issues as a result of not paying attention to polypharmacy. Next slide, please. So there's the whole issue of what we've talked about with multiple chronic conditions. And we've got this balance that we have to thing. And I just want to bring your attention to that red box there about the excessively tight disease control. You know, these are the individuals that really want their diabetes controlled very tightly, which is wonderful. But, you know, the number of emergency room visits that occur as a result of that and the hypoglycemic episodes are just more at a higher risk for older adults, and particularly frail older adults. So we have to, again, balance risk with benefit as we look at the goals. I mean, I used to have this conversation with our cardiologists, you know, the heart doctors, and their treatment of heart failure. They kept pushing all these medications maximally until the blood pressure went down to 90/60. You know, so I go like, that can't be good for a, you know, an 88-year-old, you know, patient of mine. And they said, well, it helps their, you know, if their heart's working better, the brain's going to work better. I said, no, but if they fall and break a hip, nothing's going to be working anymore. So you can just see the specialist perspective, and we're going to talk about that in a second here. Next slide.
Dr. Jervich, I'm going to be sharing the slides because Chris is in the middle of a fire drill at the College of Nursing.
Oh,
So I'll share
yeah.
my screen.
It's a good opportunity to take a hike in the hills over by University of Utah.
I believe
Okay.
this slide.
Yeah, thank you.
Okay.
Thank you for the transition. Yeah, that's good. Yeah, so the barriers to de-prescribing is that we have issues about provider time. I can attest to that. You know, when you're given 20 minutes and you got to cover the 3 problems that the patient has, not to mention our geriatric assessment, no time. There's not a lot of education about providers to even think about this. It's not routine for us to think about drug side effects. And so just inculcating that into our thinking is a big deal. And that's why we're raising this issue as for team members, all of us, to be very vigilant of medication side effects. The other problem is that sometimes the patient just doesn't want to be, deal with it. They said, oh, my psychiatrist gave that to me. I said, yeah, but you're on 3 antidepressants. I mean, how's that working for you? It's just, well, it's my psychiatrist. I said, well, with all due respect to your psychiatrist, I think you only need 1, maybe 2. So why don't we talk about, reducing one of those, because they're causing problems like falling. Yeah, and then the other problem is that, we don't always talk amongst each other. So, again, there's that tension between the primary care person and the specialist. Next slide, please. And that's exactly what's demonstrated here, is that the primary care providers, whether it be nurse practitioners or physicians, sometimes don't really feel comfortable making changes. I mean, I can't tell you how many times I've discontinued amiodarone written by a cardiologist because, of muscle problems created by the medication. Of course, in that instance, I called the cardiologist up and asked him what can I replace it with. But again, it's that communication issue of trying to come to terms and not being afraid to make these changes. Next slide, please. So some of the additional barriers, for de-prescribing is that sometimes, quite frankly, people are brainwashed. They see these commercials on TV. That's the medication for them. There's what I described about the prescriber fears. That second point is that there's sometimes insufficient evidence to support a medication, and they may not be aware of that. And just all the other fears that occur because you took this medication off and something bad happened. And quite honestly, it's a real fear. I mean, I took somebody off of a proton pump inhibitor for their stomach situation, and 2 weeks later, they wound up having a gastrointestinal bleed. Now, whether the 2 events were related or not, I don't know. I mean, but the indications were very clear for the de-prescription, but it gives you pause for thinking like, did I do something wrong here? And we do re-review some of these things, and in this case, this was an unpredictable side effect, and it had nothing to do with the de-prescription. And then finally, that point about the family's insistence, or even the patient's assistance, they get used to a certain medication, and that's why I always ask them. I said, do you think this medication is making any difference? And as soon as they hesitate and they say, I don't know, that's a goner medicine. Get that one off. So that's my litmus test. Okay, next slide, please. So let's walk through the de-prescribing process. This is a team effort. Next slide. So just the notion of de-prescribing is it's a process, right? It's not a one-timer like they say in hockey. You want to withdraw medications that are inappropriate. We don't want to get rid of everything, right? And so it's a way of managing polypharmacy, and by doing so, we're going to improve outcomes. This is called iatrogenic disease. When you have a medication that's having a side effect, it's called iatrogenesis. Next slide, please. So the first thing is communication, and first and foremost, the patients may really be connected to their medicine psychologically. They've been taking it for many, many years, and even the thought, I mean, the big one is, Ativan for sleep. I've been taking this all my life. It's a tough one, to wean, but they're psychologically connected to it, even though things like Ativan only provide 30 minutes of extra sleep, and it's not very good sleep. The process needs to be shared. Okay, so it has to be open-ended as to what the goal is. And again, that icebreaker that I mentioned, are these medicines making any difference? Do you think that they're helping? Next slide, please. So these are some of the thoughts that come about the psychological connection to medications, the inconsistency of advice. There's the issue of just confronting one's lifespan. I was told to take this medication until I die. And are you telling me now that I'm going to die? So that kind of withdrawal, and actually, the answer is no, we're trying to help you live longer. But on the other hand, you can see the conundrum that happens with this. Next slide, please. So basically, you want to, in the process of deprescribing, is to align each medication with what they're supposed to be doing. And then you want to go through and say, is this a high-risk medication, a low risk? So we know certain medications are high risk, such as the antidepressants, but the benefit may be that they're, in a vegetative state without the medication. So again, the risk benefit is in favor of the prescribing rather than the deprescribing. Next slide, please. And the idea is that, for whom, when, what, and where, it's basically every opportunity we have. And so that's the practice of the geriatric 4Ms, is that we look for every moment with every interaction as a way to review the medicines and to find out if there's a opportunity to deprescribe any of them. Next slide, please. So I want to quickly go through the efficacy these deprescription programs work. Next slide. There's over 100 studies. One study from Australia in particular was very impressive. They found that through a deprescription program that they reduced in older adults at least 2 and sometimes more medications as a result of that. So that's pretty effective. Next slide. My favorite, as being a geriatrician, is that geriatric assessment works. And in this case, they even had a better one where they averaged 4 fewer medications. And again, this doesn't happen all at once, right? This is a one-time assessment that then has some follow-up, and you move forward. Importantly, another study showed that you can reduce antipsychotics in long-term care. And the key point in those studies, there were 7 of them, showed that over 80% of the residents had no change in their symptoms or no increase in their symptoms as a result of getting rid of the antipsychotics. So you got a pretty good probability of getting rid of those antipsychotics and not having any further issues. If anything, a lot of the antipsychotics were being utilized to cover up unresolved pain, and particularly in the cognitively impaired older adult. Next slide, please. And this is what geriatricians look at. Our number 1 drug that we want to get rid of are the benzodiazepines. Those include Lunestas and all the sleepers. The atypical antipsychotics are high on our list, and so forth. You can see the easy pickings are the proton pump inhibitors. Sometimes the proton pump inhibitors like omeprazole or lansoprazole can be given intermittently, like maybe once or twice a week rather than every day. I don't know why number 9, opioids, was low on the list for geriatricians, other than the fact that it's more than likely geriatricians deal with a lot of palliative care. And so maybe we embrace opioids a little bit differently than a primary care practice. Okay, next slide, please. So to answer your question here that we had in the poll, it's the Beers list. There's a bunch of other either guidelines or tools that can assess either medications that are harmful or have drug-drug interactions. And so you can download the Beers list from the American Geriatric Society website. So if you just look at American Geriatric Society and then do an engine search for Beers list, it'll pop up for you. Next slide, please. Yeah, and these are the medications that we try to target for reduction or not even prescribing. So for instance, like we're rethinking the whole process of sulfonylureas, which are used in diabetes, glipizide and so forth, pioglitazone. All of those are can increase emergency room visits when they're used, especially in conjunction with other diabetic medications. Vitamin E, for those that don't know, most of the research shows that you shorten your lifespan if you're taking vitamin E supplement. So word to the wise on that one. Next slide, please. All right, so let's go for our wrap-up questions here. So if you can launch the poll. Okay, same questions as we had before. What's the best tool to recognize unsafe medications? And then the second question, deprescribing does what to the following? So if you can answer your question and then submit, that would be wonderful. I think we can maybe open it up for a few questions here before we launch into the quality improvement. So if anybody wants to unmute themselves and ask a question, that would be a-okay with me.
We had a question in the chat, actually. They are working with a pharmacist to consult on unnecessary medications, but they're wondering if there's a study or a resource out there that could help them understand the benefits so they can educate their family and residents about it. Do you have any recommendations?
Well, there's multiple studies. I mean, that the one slide that I showed, so indicated that there were over 100 studies, and so the best resource, quite honestly, comes from Canada. There's a few. I think it's the McMaster's University. So if you go, I think if you just Google Canada plus deprescribing, it'll probably take you to their site. I haven't done it recently. But they have a great deprescription protocol, and it's a whole website dedicated just to deprescribing.
And I think this is Catherine.
Yeah.
Cynthia, you are welcome to bring any of those tough cases to the UW Echo and geriatrics, where we have a geriatric pharmacist, geriatric psychiatrist, folks and a geriatrician, folks who can really help if there's a particularly tough case or theme there between and among patients that you would like to look at. That can be a really good way. Almost all that we do on that network is deprescribe. I don't know if other people have that experience on other echoes as well, where you're doing more applied casework. It's wild how much deprescribing we do.
Yeah, that's wonderful. Yeah, I'm glad to hear about that resource, and I would encourage everybody to use that and to certainly engage your consultant pharmacist. So just as a heads up, from our on the North Dakota side of the consortium here, we just established a new long-term care pharmacy consortium run by a fellow by the name of Rick Boehm from Thrifty White Pharmacy, and he's put together a consortium to talk about this very issue, both on proper prescription for things like Paxlovid for the COVID treatment, as well as the whole process of deprescribing. So, ramping up partnerships with your consultant pharmacist and having them engaged in these echo sessions is very, very well valuable, I think. All righty. Well, we can, if we have a little bit of time at the end here, we can open up to a few more questions. But I think what I'd like to do is transition into our quality improvement. So we can take it away, Jennifer.
Hi, I'm Jennifer Lochner, Quality Improvement Specialist with Quality Health Associates in North Dakota. I also work and partner with the Great Plains Quality Innovation Network. My colleague Jean Rowland will be assisting me with your answers in the chat today. Next slide, please. Last week, Adrienne and Jean talked about step 9, prioritize quality opportunities in Charter PIP. Have you used the copy prioritization tool? What areas did you prioritize? And share your experience developing a PIP charter. You can share those in the chat if you would like, please. Next slide, please. Your PIP charter can A, be used on state surveys, B, keep your team on track, C, keep your project on a time schedule, D, help you win the lottery, or E, A, B, and C. If you could answer that question, please. Next slide, please. Today we will be talking about step 10, plan, conduct, and document PIPS. CMS defines PIPS as a concentrated effort on a particular problem in one area of the facility or facility-wide. It involves gathering information systematically to clarify issues or problems and intervening for improvements. Next slide, please. There is a goal-setting worksheet in the Copy at a Glance guide, which you can find by using the link posted in the chat. You can use the SMART formula to develop a goal. So SMART stands for specific, measurable, attainable, relevant, and time-bound. Next slide, please. Specific. So we start with the S. Describe the goal in terms of 3 W questions. What do we want to accomplish? Who will be involved or affected? Where will it take place? Next slide, please. Next is M for measurable. Describe how you will know if the goal is reached. What is the measure you will use? What is the current data figure? For example, count, percent, or rate for that measure. What do you want to increase, decrease that number to? Next slide. The A is for attainable. Defend the rationale for setting the goal measure above. Did you base the measure figure you want to attain on a particular best practice, average score, or benchmark? Is the goal measure set too low that it is not challenging enough? Or does the goal measure require a stretch without being too unreasonable? Next slide, please. The R is for relevant. Briefly describe how the goal being set will address the business problem stated above. Next slide. Finally, the T is for time bound. Define the timeline for achieving the goal. What is the target date for achieving this goal? It's a good idea to post the written goal somewhere visible and regularly communicate the goal during meetings in order to stay focused and remind caregivers that everyone is working toward the same goal or the same aim. Next slide, please. Aim versus goal. They should not be confused with one another. Next slide, please. An aim is a vision or general description of the outcome which may include goals. Next slide, please. A goal is a specific and measurable outcome. Next slide, please. The Plan, Do, Study, Act, or PDSA cycle is a useful tool for documenting a test of change. Running a PDSA cycle is another way of saying testing a change. You develop a plan to test the change, which is your plan, carry out the test, do, observe, analyze, and learn from the test, study, and determine what modifications, if any, to make for the next cycle, act. And the link for the toolkit should be in the chat. Next slide, please. Plan. Plan the test, including a plan for collecting data. State the question you want to answer and make a prediction about what you think will happen. Develop a plan, test the change. Who, what, when, where. Identify what data you will need to collect. Do. run the test on a small scale, carry out the test, document problems and unexpected observations, and collect and begin to analyze the data. Next slide, please. Study, analyze the results and compare them to your predictions. Complete as a team, if possible, your analysis of the data. Compare the data to your prediction. Summarize and reflect on what you learned. Act, based on what you learned from the test, make a plan for your next step. Adapt, make modifications and run another test. Adopt, test the change on a larger scale, or abandon. Don't do another test on this change idea. Prepare and plan for the next PDSA. Next slide, please. Through my work with the Great Plains Quality Innovation Network, we came across a medication PIP that a South Dakota nursing home created. I changed the names and anything else that would identify them. So the start date was July 1st of 2018. The review date was monthly, and this is ongoing for them. They listed their pharmacist as the project leader and the team members, which consisted of a psych provider, nurses, and pharm techs. Their key area of improvement was broadening gradual dose reductions from any antipsychotics to now including all psychoactive medications, which included antidepressants, anti-anxiety, sleep aids, and memory enhancers that would be flagged twice in the first year of initiation and then yearly after, unless contraindicated. The reviews would be correlated to the MDS schedule. Their SMART goal was that these GDR flags would be initiated monthly following the MDS schedule. Their target threshold was to have the psych provider address 70% of the GDR flags by the end of the year. The addressed flags would include acted upon GDR flags and those flags with written justification for provider's decision. The root cause for this undertaking was the broadening of the CMS guidelines in relation to psychoactive medications. Also, this PIP deals with F329, unnecessary drugs, because the flags that are generated would, in their hopes, trigger trial GDRs, which would then justify the medication's continued use in therapy. Also, the increased scrutiny of the GDR flags would address inappropriate or off-label use of many of the therapies by calling the stated diagnosis into scrutiny by the pharmacist, DON, or medical officer. And then they have their barriers. Provider buy-in to the whole GDR process and scope. Electronic charting makes it more difficult to ascertain medication start dates due to meds all being updated on readmit, etc. Electronic charting makes some record keeping cumbersome or difficult to find later or review later. Follow-up charting or outcome charting is an ongoing difficulty, and lag time in the provider making changes in the flag GDRs does skew data. Next slide, please. And then they have their brainstorming. Continue to improve and increase pharmacist provider communication. With increased use, electronic record keeping becomes less cumbersome and somewhat more streamlined. Throw out duplicated GDRs that haven't been acted on yet. They move down to their plan, do, study, act. The list task to be done was generated MDS schedule, which was done by the nurses. The start date was July 1st and the completion date was also that day. The patients come up on the MDS quarterly, so schedule works well, and they adopted that. The next one was generate GDR flags of all psychoactive medications from the MDS schedule. That was done by their pharmacist on July 1st and completed on July 27th. And this was pass GDR flags to provider in smaller increments, and they adopted that. And the next one was action response to GDR flag by provider. This was done by their CNP. It was started on July 27th, and this was ongoing. Finally, on the bottom, you can see that during each measurement, they were meeting their goal of the psych provider addressing at least 70% of their GDR flags. Next slide, please. Creating your PIP can be so simple just by using the correct template. The GP Quinn link for this PIP template will be posted in the chat. Emily Schneider, the ADON and infection preventionist from Marion Manor in Glen Ullin, North Dakota, has shared her nursing home's PIP for pressure ulcers. This was her first time heading a PIP on her own, and she has done an incredible job. You should have all gotten a PIP template that you were given to fill in your data. If you did not get one, please reach out to your QIO and they will send you one. On their PIP here, they have their start date and review date and the PIP squad members. The PIP team leader should ask whether team members are willing to commit to the work that needs to be done before the project starts. If for any reason someone can't participate, whether it's based on lack of expertise, availability, or any other valid reason, the PIP team leader, may need to seek a replacement. Their key area for improvement is routine repositioning of residents. Their SMART goal is to reduce the risk of future pressure sore development by increasing nursing staff compliance with repositioning of at-risk residents that use their bed as their primary sleep furniture to a rate of 90% by October 16th, 2022. They did the 5 whys to find the root cause, which was lack of cues and materials in resident rooms and misunderstanding of understanding, lapse of education regarding position changes. Their barriers were staff compliance, need extra materials placed in rooms to make projects successful. Next, they brainstorm solutions. Education in-service meeting regarding importance of repositioning, pillows to be introduced, repositioning timesheets needed in room as reference, and they decided observations and audits needed to be done. Next slide, please. Then they have their PDSA portion. The task to be done for their plan was education on repositioning, repositioning time reference cards in resident rooms. Their OT and PT did this education on March 16th, which I believe is when they had their in-service. Comments, lessons learned were don't take basic education for granted. Staff needed reminders. Nursing staff indicated they wanted a different repositioning card, and PT adjusted the reference card for staff. The next one was, zoom in here a little bit. The next one was red pillows introduced and placed in resident rooms for use. The ADON and DON had done this also on their in-service day on March 16th. If pillows are not in the room, staff often will not go and retrieve per self, so extra pillows were retrieved from storage area and red pillowcases placed so it was ready for staff use. And their last one was audits observations for repositioning compliance. This was their ADON, their DON, and nurses, and they had their dates there for their pre-education, their 1 week post-education, 2 to 4 weeks post-education, and goal is daily audits Monday through Friday as staff are able for 1 month, for the first month. The actual completion date, they have those listed there, and then continued ongoing audits. Comments, lessons learned, noted increase in repositioning after education session and with the placement of the red pillows in the room, and will continue to monitor after the 1 month mark. Will decrease audits to 2 times weekly versus daily, Monday through Friday. Next slide, please. Oops, I jumped ahead here. Okay, so pre-education percentage of staff using reposition of pillows during audit observation was 15%. 1 week post-ed results was 69% reposition pillows used during observation auditing. 1 month post-education results was 75% reposition pillow used during observation auditing. And after 1 month mark with monitor progress monthly, bi-weekly, or 2 months, then depending on results may go monthly audits only. If the state surveyors were to ask what they have done to prevent their pressure ulcers, they could pull this out and show the progress they have made. And she had also done some bar graphs and line graphs, which were really great too. So they really did a wonderful job with theirs. Next slide, please. So we'll go through this blank PIP, and just, there are PIPs out online that you can look for, but if you're looking for one, make sure that it is for medical use and that they have these key points here. That you have your start date, review dates, and completion date. You're going to have your project leader and your squad members. You'll have your key area of improvement and your SMART goal. And you'll list your root cause or 5 whys. And you will have your barriers listed out, and also you'll want your brainstorming. Next slide, please. And then you'll have your PDSA, your Plan, Do, Study, Act, and your benchmarks. So you'll have your baseline and your measurement dates and your comments there. So those are your key points you'll want. If you do print out the slides, you'll have those pointed out for you. Next slide, please. Please answer in the chat, what was one thing so far in this Echo series that has sparked excitement for you to create your PIP? And I have one more question too that you can answer in the chat in this next slide, please. For those of you who have done a PIP or are in the process of working on your PIP, please answer in the chat, what challenges have you faced while developing your PIP? Next slide, please. And your PIP charter you can answer here. And I don't know, will this show us the results that people have chosen? Megan?
Oh, Julie is in charge of the poll.
Okay.
Julie, are you here?
I am here. My screen was weirdly frozen for a moment. Yes, I can share the results for you. We're over halfway, so I can go ahead and stop and we can share results.
Okay, yeah, go ahead. Yes, and E is correct, A, B, and C. So it can be used on state surveys. You want to pull those PIPs out and show them all your work that you have done. And it'll keep your team on track and it'll keep your project on a time schedule. So it's helpful for all of those things. Next slide, please. So for homework for next week, now that you have identified an opportunity for improvements, begin the process of developing a PIP around that topic. Next slide, please. Any questions? I know I went kind of fast, but I had a lot of stuff.
So Jennifer in the chat,
Yep.
Christine Dumphy responded to your question about what sparked excitement. And she said, this is very encouraging. I think just having the series is motivating me to work on my department stuff. So thank you for sharing that. And as far as challenges, she also shared that time has been a big challenge. They just have so many projects going on. And I think this is where she would want to pull in the prioritization tool, excuse me, that was shared last week.
Yes. Yeah.
So I think I was just going to add, Dr. Jervich here, conceptually, to try to reduce the time that it takes to conduct a Plan, Do, Study, Act cycle, that we're really looking for these shovel-ready opportunities. And so that's, like I say, something to think about. I mean, there are resources out there, where you can kind of fill in the blanks, But one of our considerations moving forward as we look for next year's opportunities for this particular ECHO project is to work together on a PIP and go through different cycles so that you don't have to reinvent the wheel. So that's the one thing. And then the other, I don't know if you want to address that from our QIO consultants here, but this question about others not wanting to try changes, that sort of, you know, what I call the refuseniks. What say you about those folks?
I think you just always got to turn it around and look at doing what's best for the patients, for the residents. Sorry.
I
Yeah,
think
I
also,
would agree. Go ahead, Jean.
well, I think also that when you have somebody who's unwilling, pulling them in and trying to engage them despite that can transform them into your biggest proponents for what you're doing. Once they see work in action, I think they're more apt to conform. But some people just can't seem to wrap their arms around change. It's difficult.
Yeah, and I would add that training in QAPI, so you know, maybe even encouraging them in some way, either as a staff member, as an assigned work to look at these videos that we've got posted, might be one way to get them engaged. I know that incentivization, like, you know, your promotion or whatever future salary increases might be linked to engaging in quality improvement, but they have to be trained. And so once they get the bug, maybe they'll be, you'll convert them from refuseniks to, as Jennifer says, very enthusiastic participants. So we wanted, maybe we want to move on to Carmen here and talk about ageism.
Here we go. So here's some words you guys came up with. Old. One of you said that my mother says I'm an old lady. So the silver tsunami. Catherine, I love how you said, is a tsunami ever a good thing? Kind of goes with grain of America. Certainly we've all heard old folks home. And check this out. A woman asked Christine in the nursing home, please get me my oil of old lady for my face. So oil of Olay. Haven't heard that one. And then boomer came up twice, everyone. And I kind of looked it up while this is all happening. And guess what? A boomer is now known as a grumpy old person. Isn't that interesting? So here's some that I wanted to draw our attention to today. So beware of subtle pejorative language. And my big examples, everyone, we've all done it, but look at, you know, think about how this sounds when I say, oh, we let our residents sleep in, or we allow our residents to have a pet, or we permit, you know, there's this weird overlay that kind of indicates we're in charge of you. And it's just a wonderful calling out, if you will, where we can just try to stop it and be equal. You know, what I love pointing out is we're all adults. So I didn't let you watch the webinar today. You didn't let me come, you know. We don't let fellow adults sit here or there. And so just kind of a reminder, sadly, in the institutional model, this happens, you know. And so what are some more positive ways to say it? We support, we encourage, we honor. And then on that note, I've mentioned the new dining practice standards. I'm so sorry, you know, there's so much I could have taught. I mostly kept with language, but in our dining practice standards, we have a section, look at what it's called, Shifting Traditional Professional Control to Support Self-Directed Living. That's really a beautiful way to say what we're doing here. Next slide, please. Also, we have here something I wanted to remind you all. Among the Kirs, that's people from Kyrgyzstan, elders are revered and honored. This man is called an Aksakal, a whitebeard. Once a man reaches this status, he is considered to possess wisdom, which younger men lack. Isn't that cool? We really can learn from other cultures. Do we value, revere, and honor older age? Do you proudly say your age? I'll take the next slide, please. Are you proud of your gray hair? Did you know that in some cultures, people actually dye their hair gray? That is shocking, don't you think? And so notice, even look at our forefathers, they wore the wigs, right? To look wiser, older, to be a sage. And then in our culture, is aging good or bad? I think we know the answer. Think about anti-aging. Like, what does that really mean, everyone? I hope everyone knows if you're not aging, you're not here. How dare we refer to anti-aging, right? And then like my neighbor will say, she'll say, she'll say, thanks for putting up with us old people, or we're going to the phone store and I can just see those kids rolling their eyes. That's ageist towards the kids and also to them being older. Many people refer to the senior moment. I love saying, hey, when you were a senior in high school, did you have moments where you didn't remember stuff? We didn't call it a senior moment then. We didn't call it a 5th grade moment when we didn't think of something in 5th grade. And then I'm guilty, guys. I want to tell you one quick one. On our birthday, I have a best friend. Our birthdays are close and we've been friends since kindergarten. So I said, happy birthday, but I'm not going to say how long we've known each other. And I caught myself. That is ageist right there, where I'm not proud of it. So I'm proud to tell you all, I've been best friends with my best friend for 50 years. And next slide, please. Who can say that, right? 50 years. And then I wanted to share with you a resource. I happen to be a co-editor for an international journal called Activities, Adaptations, and Aging, Dignified and Purposeful Living for Older Adults. And we wrote an open access editorial, and we're now asking anyone who submits to our journal to follow these guidelines, how to avoid ageist language in aging research. So if you're interested, there's the link, and thank you so much.